It's good to see everybody online. Prof. Ali is having issues with load shedding. He was supposed to facilitate this session, so I'm going to do that. He may or may not be able to join as the meeting progresses. But in any event, welcome to all of you. As you know, GECO is hosted by the Gastro Foundation in association with Project ECHO at the University of New Mexico. These sessions are run every second Monday at 6 p.m. We also have the surgical sessions that run every Monday at 4:30. So if you're interested, please join. And the chat will be open for questions, but obviously at the end of the presentation, we will open it up for questions that you might have for Dale. Our presenter today is Dale Petersen. He's based at Tygerberg Hospital and has just reminded me that he's almost ready to write the next exam. It just shows how quickly the time goes. Yeah, I think that's all I need to say. We've had a couple of registrations. I'm not sure how many, but quite a few. Dale, I'm going to hand over to you. He's presenting on IBS, and then we'll take it from there. Thanks so much.
Good evening, Prof. Good evening, colleagues. Thank you so much for your time. Let me just get my presentation. Is the presentation coming up clearly there, Prof?
Not yet.
There we go.
Yeah, it's looking good.
Excellent. Yeah. Okay. Thank you very much, colleagues and friends. So this evening, I'll be presenting irritable bowel syndrome. The presentation I put together is focusing more on the practicalities related to diagnosis and management of irritable bowel syndrome. So irritable bowel syndrome is the most prevalent functional gastrointestinal disorder, which accounts for about 4.8% of referrals to a gastroenterologist. Up to 16% of all patients with recurrent abdominal pain or disordered defecation are diagnosed with IBS. IBS diagnosis has moved away from an exclusion diagnostic practice and now involves a positive limited diagnostic strategy, which requires careful history and physical examination and a select limited diagnostic panel. So if you look at the prevalence of IBS, it's the seventh most common diagnosis by primary care physicians. It seems that in South Africa, we live in a very high disease prevalence area, about more than 5% on average. And when looking at diagnosing IBS, we have a new Rome 4 criteria, which has been released. We will go through the variations between Rome 3 and Rome 4 and what are the clinical implications thereof. Rome 4 states that recurrent abdominal pain on average of at least 1 day per week in the last 3 months associated with 2 or more of the following criteria related to defecation. The key with related to defecation infers that the condition or pain may either be worsened or may be improved by defecation. Change in stool frequency, it's associated with the change in stool form or appearance according to the Bristol stool chart, and it needs to have been fulfilled for the last 3 months with symptom onset in excess of 6 months before a diagnosis is made. Very importantly, Rome 4 only applies in the absence of alarm symptoms, and hence the strong advocation of a good clinical history and a good physical examination needs to be implemented before one can apply the Rome 4 criteria. So the alarm features that one should look for is symptom onset in excess of 50 years with no prior colon cancer screening have been performed, unintentional loss of weight, recent change in bowel habitus, usually less than 3 months, nocturnal pain or passage of stool, unexplained iron deficiency anemia or positive fecal occult blood test, family history of inflammatory bowel disease or colon cancer, overt gastrointestinal bleeding, fever, and palpable lymphadenopathy. So if these features are found, one should pursue these symptoms and manage accordingly. So Rome 3 versus Rome 4. So the change with regards to Rome 4 is that abdominal discomfort has now been removed from the diagnostic criteria, as well as the symptom interval or symptom interval intensity has moved from 3 days per month to 1 day per week. And then the other aspects of the diagnostic criteria related to defecation, as I said before, either improving or worsening. It's no longer the onset of associated change in frequency, but just a general association with changes in frequency and stool appearance according to the Bristol stool chart. So the impacts of this clinically and how this relates to the pathophysiological factors is that about 85% of patients that fulfill the Rome 3 criteria now actually fulfill the Rome 4 criteria. The Rome 4 criteria patients were more likely to be female. They had a poorer health-related quality of life. They had more severe pain, bloating, fatigue, and visceral hypersensitivity. Equivalent degrees of anxiety and depression were prevalent. The IBS subtypes did not differ, and the bowel habit dissatisfaction and oral anal transit times did not vary. The number of severe pain days did correlate well with symptoms and visceral hypersensitivity. So very important and crucial in terms of implementing management and accurately ascribing an IBS subtype would be the Bristol stool chart. So there are actually 4 types of IBS subtypes. The one that's not illustrated in the diagram is the unspecified subtype. It's a subtype that doesn't really fulfill any of these common entities or common subtypes. So the IBS with constipation, this would require at least more than 25% of a type 1 or type 2 Bristol stool chart, and less than 25% of Bristol 6 and Bristol 7. The diarrheal predominant subtype is the inverse of this, having more than 25% 6 and 7 Bristol stools and less than 25% of the type 1 or type 2 Bristol stool. The mixed subtype is again a combination of the two. Why this is very important and crucial is that your management strategy or your pharmacological management strategy is dictated by the subtyping. So in the consultation setting, one should actually show the patient the Bristol stool chart, discuss the frequencies of their particular stool type, and they should actually sort of show you which one is more relevant. Okay. So with regards to the pathophysiology, so it's a disruption in the gut-brain axis. Okay. So typically patients who have IBS typically are more likely to have higher stress levels or have higher traumatic emotional stress-like events within their lives, have higher likelihood of depression, anxiety. This is associated with dysfunction in the microbiota, increased permeability of colonic epithelial cells, particularly the tight junctions, which allows immune-mediated cells such as dendritic cells to be exposed to antigenic material. And this then creates an aberrant inflammatory milieu within the colonic mucosa. And this, needless to say, has an impact with regards to visceral hypersensitivity and pain perception of these patients. In combination with this, you have dysregulated gut motility, visceral hypersensitivity, low-grade mucosal inflammation has been actually biopsy proven in patients with IBS. Prolonged post-infectious gastroenteritis has also been implicated in changing the inflammatory milieu as well as the microbiota. The microbiome itself, either long-term exposure to antibiotics has also been, or recurrent antibiotic exposure has also been implicated. Patients with food sensitivities, family history, as well as marked psychosocial dysfunction. All of these in concert predisposes a patient to developing inflammatory bowel disease. And this just really illustrates that the environment in combination with the intrinsic dysregulation impairs the central processing of the patient's symptoms, as well as impacting on the patient's normal gut control mechanisms, resulting in irritable bowel syndrome symptoms. Established risk factors that have been implicated: patients in the age group of about 60 years old, females, smokers, patients with adverse life events. This is also very important in that patients with irritable bowel disease, irritable bowel syndrome, are more likely to have had an emotional traumatic life event. They've been shown that they are more likely to have had prior sexual abuse, physical or emotional abuse. And why I want to illustrate this point is that in the consultation process, you have to lend a sympathetic ear and be really patient and caring with individuals that present with these symptoms. They are more likely to have depression, hypochondriasis, and a history of post-infectious gastroenteritis, particularly prolonged illness period, lymphocytosis, and now as well, COVID-19 has been implicated as both an infectious agent as well as a psychological stressor predisposing patients to IBS. So what do we do when a patient presents with chronic symptoms of pain, constipation, and we suspect that this patient may indeed have irritable bowel syndrome? So we need to take a good history, physical examination, looking specifically for alarm features as mentioned before: hematochezia, chronic diarrhea, family history of colon cancer, IBD, celiac disease, fever, nocturnal symptoms that awaken the patient, symptom onset more than 50 years of age. If there are upper gastrointestinal symptoms, such as dysphagia, vomiting, if there's a short history, and you need to inquire about a travel history, particularly in patients that go to high endemic areas for Giardia. This, and as well as patients who may be exposed to lower socioeconomic backgrounds, poor sanitation are also at risk of this infection. A history of loss of weight is important. On physical examination, you should look for any obvious masses, arthritis and active arthritis, dermatitis herpetiformis, pyoderma gangrenosum, blood or mass on digital rectal examination, anemia, any features of malabsorption, and thyroid disease. If any of these entities are found, you should pursue a diagnostic strategy addressing these features. Okay. If your physical examination reveals no alarm features and the physical examination is otherwise normal, a positive diagnosis of IBS can be made using the Rome 4 criteria. Furthermore, if a patient fulfills the Rome 4 criteria, one should select a very limited positive diagnostic screening strategy, and this would encompass a full blood count, a CRP, a celiac serological test, especially for those who have IBS diarrhea predominant features, as well as fecal calprotectin in combination with a CRP, which has a very high negative and positive predictive value to exclude inflammatory bowel disease. The patient should be accurately subtyped with a Bristol stool chart, and then a treatment strategy should be based upon the predominant symptom, whether it be constipation predominant or diarrhea predominant. So what are the diagnostic guidelines that have been stipulated by ACG? So they say a positive diagnostic strategy as opposed to an exclusive strategy. The reason for this is that with an exclusive strategy, the cost implications are enormous, as well as there is a significant delay in terms of initiating therapy, which then translates to poorer outcomes, poorer patient outcomes. A celiac disease serological testing for IBS diarrhea predominant patients, as it's been found that up to 3% of patients who have been labeled IBS diarrhea predominant in actual fact have celiac disease. Beyond that, the consequences of missing a diagnosis of celiac disease with regards to it is something that can be managed with a gluten-free diet. It does have malabsorption consequences, as well as the risk of malignancy. So a tissue transglutaminase level as well as an IgA level should be performed. And if an upper endoscopy has been decided upon, 6 biopsies of the duodenum, including the duodenal bulb, should be performed. The duodenal bulb is essential to make sure that you do not miss ultra-short celiac disease. A fecal calprotectin or fecal lactoferrin plus a CRP is superior, especially in patients with IBS diarrhea predominant symptoms without alarm features, in order to rule out IBD. Cutoff values of less than 50 for fecal calprotectin and a CRP of less than 5 have an extremely high negative and positive predictive value. The fecal calprotectin is not an easy test to perform. It requires meticulous processing. The stool specimens need to be taken accurately and obviously processed in a timeous fashion. No routine stool testing for enteric pathogens is allocated or advocated unless the patient has a high pretest probability or has definite risk factors for Giardia exposure, as mentioned before. The role of routine colonoscopy is not advocated, especially in patients who are under the age of 45 who do not have warning signs, i.e. a history, family history of IBD or family history of colon cancer or any of the other colonic alarm features. If a colonoscopic strategy is pursued, you need to obtain biopsies in patients with IBS diarrhea predominant symptoms. The accurate subtyping of IBS is crucial as this dictates management, and your management has implications with regards to outcome. No routine food allergy testing or food sensitivity testing is required unless on history the patient has identified certain culprit foods that have resulted in a resurgence in symptoms on reintroduction of these food types. Anorectal physiology testing for pelvic floor disorders and refractory constipation needs to be excluded, especially in patients who do not respond to standard medical therapy. So with regards to pelvic floor dysfunction, on rectal inspection, features that may lead you towards suspecting this abnormality: dermatitis, perianal erythema, rectal prolapse, a gaping anus, hemorrhoids, fistulae, fissures, needless to say fistulae, would alarm someone at the risk of possible inflammatory bowel disease as well, rectal scars, anorectal masses, and digital rectal examination findings impaired sensory perception of stool. So on an insertion of the examining hand, obviously gently, the patient may experience significant discomfort in the absence of any obvious mass lesions that one detects, rectal distension and stool impaction on examining, and abnormality with regards to abdominal, diaphragmatic and rectal contraction on insertion of your examining finger. You could ask the patient to gently try to expel the examining finger with your other examining hand on the abdomen. Abnormal contraction or recruitment of abdominal muscles would alert someone to the possibility of a pelvic floor disorder. Abnormal relaxation of the external anal sphincter and puborectalis muscles would also alert one to this abnormality. What the ACG advocates is that you require at least two positive tests out of 3 with regard to anorectal physiological assessment. This would be anorectal manometry, a balloon expulsion test, and defography. So 2 positive tests revealing dysynergic defecation or pelvic floor disorder is required to make the diagnosis. I focused on anorectal manometric assessment because it just gives a really good visual idea as to what's happening on a pathophysiological basis. So your barrier mechanisms, your puborectalis, your external anal sphincter and internal anal sphincter. In the rest state, it does have a level of tonicity in order to prevent incontinence. So during the normal defecatory process on reception of feces into the rectum, increased rectal pressure results in the activation of an inhibitory rectoanal reflex, which results in relaxation of your external anal sphincter and internal anal sphincter, which allows for the passage of stool. So how this relates graphically is that within a normal response, increased rectal pressures, your anal pressure drops in order to allow for the expulsion or for normal defecation to occur. In patient with dysynergic defecation, either you have a non-response or a non-reciprocal drop in your anal pressures, or a reciprocal rise in anal pressure in response to an elevated rectal pressure. The importance of this assessment is in patients that have these positive tests, these may well be a marker of poor response to medical therapy, as well as patients who may respond well to gut gut derivative psychotherapies such as cognitive behavioral therapy, biofeedback therapy, and other alternative management forms, which I will discuss shortly. With regards, so putting all of this together, the general diagnostic algorithm that we should follow is a patient symptoms suggestive of IBS. We take a good medical history, good physical examination, teasing out whether alarm symptoms are present. If they are present, you implement a patient-specific investigation protocol. If these are absent, a limited screening protocol involving a full blood count, CRP, fecal calprotectin, as well as a celiac serology, only in diarrhea predominant disease. If there are any abnormalities on your limited screening protocol, you should pursue and manage accordingly. If no abnormalities are detected, you can then apply the Room-4 IBS criteria and then subtype your patient accurately using the Bristol stool chart, and then decide on your pharmacological treatment strategy. Okay. So the initial management goes without saying. A provider-patient relationship is extremely important, as it's been implicated that physician negativity is strongly related to poor outcomes. In developing a relationship with a patient, you can ask about things such as why has the patient presented at this particular time, and what has changed. This allows you to tease out if there have been any abnormal life events that has occurred in the patient that may be a strong precipitant for a deterioration in the patient's current clinical state. Education, reassurance, and this just really allows one to manage patients' expectations as well as to address certain fears and educate and reassure accordingly. Lifestyle modifications, interrogating sort of the lifestyle, unhealthy lifestyle practices a patient may or may not have. And it gives you an opportunity to encourage things such as exercise, sleep, and stress reduction management protocols, which also lowers the patient's stress and anxiety, and therefore increases the patient's tolerance toward the symptoms and presentation, and gives the patient more power. Dietary modifications, soluble fiber diet, and a short trial of a low FODMAPs diet for 6 to 8 weeks is recommended. And then one decides on a pharmacological strategy aimed at the predominant symptom that the patient presents with, whether it be constipation or diarrhea. So the ACG 2021 recommendations with regard to management is a trial of low FODMAP diet for global IBS. This has been shown to improve global symptoms of particularly bloating and pain, but only a short trial of about 6 to 8 weeks. At 8 weeks, if the patient hasn't had any response, then this management strategy should be abandoned. This should be done with the guidance of hopefully a gastroenterology trained dietitian, or a dietitian that is very comfortable with this kind of management protocol. Soluble fiber has been shown to improve global symptoms. Sapphilum, asafoetida husk has also been associated to improve bloating, pain, and as well as constipation. They recommend against just the sporadic use of antispasmodics. The antispasmodics actually have no clinical benefit with regards to global IBS symptoms. It does have a place once your predominant symptom has been managed and the patient has ongoing abdominal discomfort. Antispasmodics in combination with tricyclics, serotonin receptor inhibitors, selective serotonin reuptake inhibitors, has a place with regards to pain management. Peppermint oil to provide relief of global symptoms. This is due to the calcium channel blocking effect. It does help with abdominal pain. One of the drawbacks is that patients can have gastroesophageal reflux associated with it. So one should use entry-coated preparations, which are now available. Probiotics, they recommend against the use of probiotics for the global symptoms of IBS, but this has to be said that probiotics has not been shown to have any sort of clinically significant effect in terms of symptom resolution or symptom improvement, but it also has no adverse effects have been implicated. So if a patient would like to use a probiotic, a clinician should give the evidence-based approach, but should also make them mindful of the fact that there is no evidence that probiotics would improve. But if they would like to use it, they can they're more than welcome to do so. With regards to pharmacological therapy, chloride channel activators for IBS constipation, predominant symptoms, as well as global IBS symptoms, lubiprostone, which is a long-acting prostaglandin E1 analog. I'll be discussing the mechanism and adverse effects as I discuss a management protocol for IBS constipation predominance. They recommend against the general use of polyethylene glycol products for global IBS symptoms. It does have a place in IBS with constipation predominant symptoms. Guanyl cyclase activators for IBS constipation, linaclotide, and pegorisad, which is a serotonin H4 agonist. What is very important for this agent is that this agent should only be reserved for patients under the age of 65 who have no more than one cardiovascular risk factor, and only if they have not responded to secretalogs. The implication of this is that it was removed from the market because of the concerns of increasing incidence of ischemic heart disease in patients. So hence it's advocated that it's only used in this select patient population, and that for the very least, all patients who are using this agent should have a baseline ECG and a very good cardiovascular assessment. They recommend against the use of bile acid sequestrants. There is a subset of patients that do have bile acid malabsorption, and I will get into that. And this agent can be used at the clinician's discretion. Certain patients that have had prior cholecystectomies, for example, who are at high risk of bile acid malabsorption, this agent can be used in patients who have IBS diarrhea predominant symptoms, not responding to first-line medical therapies. Bile acid sequestrants can be considered. There are certain biomarkers that can be used, such as fibroblast growth factor 19, as well as a C4 level. Can be used. Certain imaging studies such as a selenium HCT scan can be performed, but unfortunately this depends on its availability and whether there's the clinical expertise available to utilize this. Rifaximin can be used for IBS diarrhea predominance, a short course of no more than 14 days. 40.8% of patients respond. It does help with global symptoms, particularly with pain and also stool consistency. Alosetrin for IBS predominant symptoms. This is reserved again for females with severe symptoms that have failed conventional therapy. Tricyclics has a place with regards to abdominal pain. If pain persists despite treating the predominant symptoms, tricyclic antidepressants can be used mainly for the cholinergic effects. Gut-directed hypnotherapy, especially in patients who have dyssynergic defecatory disorders or pelvic floor disorders, cognitive behavioral therapy, hypnotherapy, biofeedback, acupuncture. This just improves the patient's cognition and the patient's sort of ability to tolerate the symptom cluster. FMT has not been found at this point to provide any therapeutic utility, although there is a paucity of evidence whether these actually do make a clinically significant difference. So with regards to IBS constipation predominant, there is a diagnostic arm that one needs to follow. And if one goes through this diagnostic arm, your first line therapy for, and especially for mild symptoms, would be polyethylene glycol product for constipation and straining. It does not have any place with improving pain. This should be added if the patient has not responded to soluble high fiber or sphugla or psyllium added to their diets. Then one can consider a peg-based therapy. This should not be something that should be encouraged as a chronic therapeutic agent, as electrolyte disturbances can occur in these patients. and actually worsen things like abdominal pain. It can worsen other features such as bloating as well. Second-line agents for moderate therapy, if they have not responded to first-line agents, then these are your secretologues. So lebisterone, which is a chloride channel activator at 8 micrograms twice a day. The mechanism for this is that it increases intestinal fluid secretion and therefore decreases intestinal transit time. Side effects related is mainly nausea, but this is dose related. So if a patient does experience nausea, you can lower the dosage, half the dose, and then slowly up titrate your dosing again. Diarrhea can worsen about 10% of patients, and headaches can occur in 7% of patients. Linaclotide, which is a guanylate cyclase C agonist at 290 milligrams daily, has a identical mechanism of action. There is no difference in terms of potency and efficacy between these two groups. The only difference is that linaclotide is associated with a higher degree of worsening diarrhea in these patients. Paclitaxel, which is another guanylate cyclase C agonist, 3 milligrams daily, and tenapavir, which is a newer novel agent. It's a locally acting sodium hydrogen exchanger. So it inhibits sodium and water reabsorption in the small intestine as well as the colon, increasing secretion as well as increasing intestinal transit time. So diarrhea can occur in about 15% of patients, and patients can actually have very severe diarrhea in about 2.5% of patients. If this agent is used and this occurs, you should stop, wait 2 weeks, and then reinstitute at half the dosage. Third-line agents, this is really reserved for refractory cases. Tegoracid, which is a serotonin 5-HT4 receptor agonist. So how this works is it initiates your peristaltic reflex, accelerates GI transit time. As mentioned before, there are some cardiovascular risks associated with it. So this treatment should be reserved for patients who are younger than 65 years, no history of ischemic heart disease, and less than 1 cardiovascular risk factor. And if this therapeutic agent is pursued, you should do a baseline ECG. So with regards to the diarrhea predominant subtype, loperamide, which has been tried and tested, it's a mu opioid receptor agonist. You can go up to dosages of 16 milligrams per day. This agent is only really effective as a prophylactic agent, as opposed to when the patient experiences diarrhea. It has no effect on abdominal pain or bloating, and very importantly, the opioid effects when reaching doses in excess of 10 milligrams needs to be considered. Things such as respiratory depression, especially in your elderly patient populations. Bile acid sequestrants, cholestyramine 9 grams BD, and cholestyramine 2 grams BD for patients with bile acid malabsorption. And these are patients, specifically those, as mentioned before, have had prior cholecystectomies, particularly one should alert one to this. And this, again, can be used at the clinician's discretion. There are biomarkers available. I'm not entirely sure if these biomarkers are available in South Africa, but can be utilized in the absence of SC-HCA-T scan. Again, rifaximin can also be used at 550 milligrams TDS short course. How this works is a non-absorbable antibiotic. So what it does is it prevents gas-forming coliforms from being produced and preventing abnormal distension of the colon, preventing worsening symptoms, particularly in patients with marked visceral hypersensitivity. It should be said that these agents should only be used for a 2-week period and addresses mostly features such as pain and the stool consistency. Okay. Ilaxadoline, which is a mixed opioid receptor modulator. The response rate is about 27 to 8% with regards to diarrheal symptoms. 100 milligrams BD has been advocated. It's very important that there There are certain contraindications, so taking a good surgical history, especially patients who've had prior cholecystectomies, severe acute pancreatitis, although very low incidence rate, has been implicated with regards to sphincter of Oddi dysfunction, sphincter of Oddi spasm. Patients with a history of recurrent pancreatitis, alcohol abuse or alcohol disuse disorder, more than 3 alcoholic beverages daily. This agent should be avoided at the risk of developing a severe episode of acute pancreatitis. Allosetron, which is a serotonin 3 receptor antagonist. In the state sector, we are fortunate to have ondansetron and granisetron as alternatives to this agent. It should be reserved for patients with females with severe diarrheal episodes. It was briefly withdrawn because of the risk of ischemic colitis and actually causing very severe constipation. But recent studies have actually disproven this entity. So there is no longer this major requirement for physician vigilance with regards to the incidence of ischemic colitis. So these agents can be used reasonably safely. So if your predominant symptoms have been addressed and the patient still has persistent pain or marked psychological symptoms, the next arm of management would involve tricyclic antidepressants, selective serotonin reuptake inhibitors, as well as antispasmodic therapy. Again, if a strong psychological component is elucidated in your consult, the use of a clinical psychologist and a psychiatric consult would be indicated. So with regards to your pain management algorithm, tricyclics, amitriptyline has the best evidence. Start low at a dose of about 10 milligrams at night, increasing up to 25 milligrams at night. They say you can go up to a maximum of 150 milligrams, although the literature says that if a patient has not responded by 75 milligrams, one should be very reluctant to increase the dose further. You should then consider an alternative agent such as a selective serotonin reuptake inhibitor. Very importantly, your TCAs have marked anticholinergic side effects, so things such as dry mouth, urinary retention, xerostomia, as well as in patients with cardiovascular risk factors. QT prolongation and the risk of dysrhythmias should also be considered. So it's always a good idea, any patients who's older than the age of 40, in the absence of cardiovascular risk factors, to have a baseline ECG to make sure that there's no risk for cardiac dysrhythmias, especially if you're going to go to the higher dosage registries. Selective serotonin reuptake inhibitors, escitalopram is the best agent in this class. It is available in the state sector. Fluoxetine is the second best SSRI. Sertraline should be used with caution. There is an increased risk of lymphocytic microscopic colitis associated with sertraline. So this agent should really not be an agent that one should consider. If you're going towards the SSRI therapy, then the consideration of a SNRI, if one has reached maximum doses of a SSRI, should be considered. But one should say that there is not much evidence for the use of an SNRI with regards to abdominal pain. But if one has to, you can explore this as an option. Antispasmodics, peppermint oil, there's good evidence for this. As I mentioned before, there are entry-coated preparations. There's no evidence for hyoscine, butyl bromide, and dicyclamine to be used just for global symptoms. Again, a patient with IBS who comes in, we should not administer this agent as a prophylactic measure unless the patient has not responded to the previously mentioned pain management strategies. It should be used as an add-on therapy as opposed to first-line abdominal pain management. So non-pharmacological options, as I did mention before, soluble fiber, low-fat FODMAPs trial. We are living in the age of smartphones. There are a number of smartphone apps available for IBS that allows the patient to keep a diary. It gives the patient some nutritional advice. It allows the patient to sort of mark out their symptom timeline. And what this really does is it empowers the patient. It really puts the patient's management into their hands, as well as for consultation purposes, the patient can then show the clinician a log of what has been happening to them in the preceding time. Exercise, and then again, probiotics, as I mentioned before, may or may not be used in a patient. There's no real evidence for this. My take-home message for IBS is that it is a debilitating condition. Certain studies have shown that patients with IBS, they've done general questionnaire in Sweden, which said that IBS patients are prepared to lose an average of 10 to 15 years of their life expectancy if they were offered a cure for their disease. The same group of patients were prepared to take a 1% risk of sudden death if a curative option is available. These patients lose a lot of quality of life hours because of their symptoms. So you really need to be delicate when dealing with these patients. An excellent clinician-patient relationship is extremely important. Validating the patient's experience. You know, we have a habit as clinicians, the absence of a pathological finding kind of creates an air of disinterest, and this actually translates to the patient. So acknowledging the symptoms is extremely important. A thorough history and physical examination, a positive limited diagnostic strategy, especially in our resource restrictive environment. It has major cost implications using an exclusive diagnostic strategy. It delays management, and it also that relates to worse patient outcomes. Subtyping facilitates management, incredibly important. It also should be said that some IBS patients actually alternate between subtypes. So a patient who initially presented with IBS constipation predominance, in a year, it says it's estimated that about 30% of patients will actually change from one subtype to another. So you actually kind of have to re-audit your history on each occasion that you see the patient. So a IBS diary in this regard is extremely important. A multidisciplinary team approach, psychologist, if need be, psychiatrist, as well as a dietitian is crucial. And then with regards to pharmacological therapy, use the lowest effective dose and avoid polypharmacy at the risk of developing adverse reactions to these drugs. Thank you.
Thank you so much, Dale. I can't see my screen properly. Can you guys hear me?
Yes, Prof.
Okay, lovely. And I'm going to see if I can, maybe if you unshare, then I'll see if I can put my camera on. I don't know if it's on or not. I'm just seeing.
There we go.
Okay, thanks. Let me just see. Are you able to see me at all or not?
No, Prof. It's just your name tag.
I'm not sure what happened to my camera. And I can't see, I've got a funny screen here. I can't see how let's see if I try that. That should be, okay, there we are. All right. Thank you so much. I thought that was really an excellent, clear and practical overview as to the management of IBS, because all of us see these patients and you're never quite sure what to do or how to go about it. So I thought you laid it out very, very nicely according to the subtype of the patient. And the first line, second line, and the third line management strategies. So as you correctly pointed out, and I'm happy that you contrasted the Rome 3 and the Rome 4 and the importance of the fact that now we're talking about pain, not discomfort. And another thing that's important to say is that bloating may be an associated symptom, but it's not a key symptom in the current diagnostic criteria. And people like to think that patients who've got bloating with a change in frequency or consistency, that's IBS. It's not. There has to be pain with a change in frequency, as you've said. So I think that's an important thing to say. And just to mention that the Rome 5 criteria are being crafted. So, but I think the changes will probably come around the globus, and those sort of symptoms, and what we call them, what names we give those. I think IBS may not necessarily change, but I'm not necessarily in on the circle. So just look out for the Rome 5 criteria. I think you've stressed something which I struggle with, that people seem to think that with GIT, there isn't anything to find in the physical examination. And so people either don't do it or they do a very shoddy job of it. And the reality of the matter is that the clues are there in the physical exam. Whether you're dealing with IBD or IBS or whatever the patient presents with, it really is worthwhile taking a proper history and doing a proper examination. And the rectal examination is crucial. And I don't know how many times I see the registrars in internal medicine, even sometimes our own registrars will go see a patient and not do a rectal. I think it's criminal. Whether the patient has got diarrhea or constipation, you want to do a rectal, because obviously the patient may have overflow diarrhea, in which case they'll be constipated, but they will present with diarrhea. There may be a rectal mass. As you say, you can assess the pelvic floor, the sphincters, etc. There's so much to be gained by doing a proper examination. The only excuse not to do it is if you intend to do a colonoscopy or flexi within a week, But if it's not going to be that soon, you want to do it because it actually may prompt an earlier booking for a procedure that you might otherwise have put off for a month or longer. So I think for a surgical and a medical gastroenterology registrar, not doing a rectal is completely unacceptable in my book. And in terms of epidemiology, you said that if you contrast Rome 3 to Rome 4, there really isn't any difference in the pain and the subtyping. But the literature does show that women with IBS tend to present more with constipation, whereas men tend to present more with diarrhea. And I'm not sure why that is. But yeah, so just think, when you have a patient in front of you, just think of the likelihood of the subtype that they may have. And in terms of the subtype, I have found I found that Bristol stool charts such an important tool to have, because people can describe their stool and describe their stool. You'll never really be on the same page with the patient until you show them the actual diagram. And I like to tell the story of a patient who was referred to us with diarrhea. And actually, when I showed him the Bristol stool chart, what he was having were pellet stools, so type 1, but he was passing them throughout the day because he's constipated. And he was being worked up for diarrhea when in fact he had constipation. So I think the visual representation is so key, because it puts you and the patient on the same page. And in terms of jotting down improvement, then again, you use the Bristol stool chart to say, this is where we were and now this is where we are. So it's very, very important. Print it out, have it in your rooms, or put it on your cell phone. You spoke very nicely about the pathophysiology, and in IBS diarrhea, because of the gap junction leak, as you rightly pointed out. In fact, these patients have been shown on biopsies to also have an increase in T lymphocytes compared to the patients with IBS constipation. So that also fits in with the pathophysiology. I like the issue of the positive diagnosis. Now, positive diagnosis, as you said, it augurs for outcomes and how you investigate the patient. But I think there's something positive about saying to a patient, this is the diagnosis that you have. Not, we're going to do this and this and this and that and exclude this and this and this and that, and then we will say that you have IBS. There's a very different mental spin on the patient when you say that this is the diagnosis that you have. There's some confidence in there. The patient can trust what you're saying. They can trust the therapy that you're prescribing. So yes, in our mind, we know that we do the other things to exclude more serious conditions. But that's not what you want to say to the patient. What you want to say is that there's an abnormality of your gut-brain axis. This was probably the trigger, the way in which your gut responds to your brain and the signals is disordered. So you have irritable bowel. I think when the patient walks out with that, I think it gives them ownership, it gives them understanding. It actually says to them that there's nothing wrong with them. They're not psycho. So I think, other than what you mentioned in terms of a positive diagnosis rather than a diagnosis of exclusion, it's really a positive message. And then your limited diagnostics, the only thing that I know is not in the guidelines, but that we should do, in addition to your full blood count, CRP and fecal calprotectin, is obviously you want to exclude common things, diabetes. So you want an HbA1c or glucose or whatever, and you want a calcium and you want a TSH, because the patient may be having hypothyroidism, etc., etc. So that's what I would include as part of your basic workup. in addition to what you mentioned. And I agree, no allergy testing unless you can, provoke an allergy, which you might not want to do. If it's a proper bona fide allergy, you don't want the patient to have a problem. But yeah, you don't test for that. Now, in terms of the fiber, soluble, why soluble and not insoluble fiber? Say in a patient with constipation.
So they say that soluble fibers, when soluble fibers interacts with gut coliforms, it's more likely to produce abnormal gas, and so that or increases gas production, which causes increased distensibility of the colon, especially in patients with visceral hypersensitivity. Yeah, that's the only real advantage that I've seen with regards to soluble versus insoluble. They say that you have greater degree of abnormal gas handling and methane production with your insoluble fiber forms as opposed to your soluble fiber forms. Yeah. So bloating and pain will be worse.
Yeah. So it does. So it has a less effect of drawing fluid into the gut.
Yeah.
And produces more gas, which in a patient who's already got issues of distensibility and perception of pain, etc., may actually worsen their symptoms. So you want to suggest soluble fiber, and how much is enough fiber to get the colon moving?
Yeah, so they say that 25 grams to 75 grams daily is what's needed.
So 25, 30, and the thing is you don't want to introduce it all at once. So it should be graded, because you don't want those complications of bloating and gas and so forth. So the patient can build it up. And if they can't get it from their food, then you can suggest a supplement. And then the patient can build up to that. So that's quite important. But also, when a patient is increasing their fiber intake, you must give the advice that they must also increase their fluid intake. And we're talking 2 to 3 liters of fluids per day. That is what should happen anyway in a patient who's constipated. But if you're going to add fiber, then they must counteract the fiber by increasing their fluid intake. While I've got you here, it's kind of off topic. What are the conditions that you know of for which probiotics are actually indicated, where there's evidence? Because people use probiotics for willy-nilly, diarrhea, constipation, abdominal pain, bloating, whatever. From a gastroenterology perspective, what are the conditions for which probiotics are indicated?
So with regards to pouchitis, VSL-3, that is one that's been that has been shown to have a benefit in reducing the length of infection, as well as small bowel intestinal overgrowth. I don't think that is very evidence-based. That's not very evidence-based. And then also antibiotic-associated diarrhea. As an adjunct to antibiotic therapy. Other than that, I'm
so
not
the other
really
two traveler's diarrhea. So traveler's diarrhea, and then in the pediatric population is enterocolitis.
Okay.
So those are the only indications that have been approved sort of for probiotics, but people use them and anecdotally, people say they work. The problem is that you need to be quite careful about the strain of the bacteria that are in there, the amounts. So all these factors they do impact on whether the stuff works or not. And a lot of it is sold, and obviously because it's kind of considered a dietary supplement, there's poor regulation, particularly in South Africa. So you're really not sure what you're taking in. So it's better actually to just have foods like yogurt or kefi or those sorts of things that have bacteria in them, or eat foods that will promote, good gut bacteria, rather than buying the stuff that you're actually not sure what it actually has, how many colonies, etc., etc. So I think probiotics, you've got to be quite careful. They're quite common in the public media. People are using them. Lubiprostone. You've mentioned everything that I wanted to hear about it, but what's the other problem with it? What's the onset of action? Is it quick or slow?
To be honest with you, Prof, I'm not sure. In terms
so the problem with it is that it takes time to work. And as you correctly pointed out, then there is this dose-dependent nausea, which sometimes can result in people stopping therapy. And in fact, in South Africa, although I believe it's available in private practice, it's actually very expensive. So it's actually quite expensive. So that's a problem with it, that it takes time. it can cause quite significant nausea, and in our setting, it's quite expensive. We don't have it in the public sector. What else is the one? And then in terms of the positive diagnosis, don't forget that actually IBS can coexist with IBD or celiac disease or food intolerance or microscopic colitis or whatever. And it's not easy to know that for sure, because as you say, there isn't really a biomarker that's specific for IBS. So if you have a patient that you're treating for a bona fide diagnosis, but they now also have pain, which is out of keeping with their symptom, or by all accounts, the other disease is in remission, you know, by objective markers, the disease is in remission, but the patient still has this pain or whatever. It is possible that the patient can have coexistence of the disease. And I think you should be careful at diagnosis when you're having a patient that you think is IBS, but they keep coming back and things don't make sense. I think go on to investigate. Don't assume that. And then the patient may not necessarily have the alarm features that you spoke about, which will prompt an investigation anyway. But you just need to be careful that there are patients who will have dual pathology. And obviously you need to go looking for that. I think that's all I wanted to say. I wonder if there are any questions. Please feel free to unmute, to put on your camera. Don't be shy. It says, I think one must consider microscopic colitis as an important differential diagnosis. In fact, yes, indeed. Badrelden, sorry if I'm not pronouncing your name. There's a long list of differential diagnoses to be considered. SIBO, microcolitis, celiac.
Especially the patients on a PPI.
The patient is on a PPI, and absolutely, so 100%. Any other questions from anyone else or comments? So you guys know everything there is to know about IBS. So the microbiome, you know, there are many aspects to IBS pathophysiology, but it's felt that the microbiome actually is the bedrock of all these other pathophysiological mechanisms. And it's been quite disappointing that FMT has not really worked. You know, the studies are poor. There's contrasting studies for benefit and no benefit. You would think that it would work, but as it stands, as you correctly say, the evidence is quite poor for FMT. But I guess watch the space. It is possible that over time, when the studies are controlled, that we may get to a place where we actually can use FMT for these patients.
Yes. Prof, what I did read about FMT, they said that there's they're looking into super donors.
Yeah.
They say that the key might be with regards to getting a super donor carefully selected for the particular patient, and that might be the turning point for FMT.
Yeah, and also the way the FMT, whether you're going via nasogastric tube from the top or whether you're going to the bottom, that might make a difference. Yes. So I think those studies are coming. Those are the all notes. Let me see what else is there. Yeah, I can't think of anything else. Are there other HODs in the meeting? Any comments? Let's see who's there. Dr. Gatley, I'm going to put you on the spot. Welcome. Do you have any questions or comments? She's gone all shy. None, any additional comments before we close?
So I'm driving. I'm sorry. I was just listening. I'm driving. I'm sorry.
Okay, no problem. All right. No, Dale, honestly, I thought that was comprehensively done. That was really an excellent talk, and I invite you guys to revisit this talk. This IBS management is a common question. It makes its rounds almost at every exam, whether it's in the written or the oral. So please familiarize yourself with this. Yeah, Dale presented the latest update AGM, so that's fine. On a separate note, I'm doing the roster for next year. by my count, most of you by the end of the year will have presented twice. If there's anyone who's presented more than twice this year, so by the end of this year, if you will have presented more than twice, please let me know, because obviously I'm trying to do this in an equitable fashion. So please do let me know so that I can take that into account. As far as I can tell, most of you should only present once next year, once, maximum twice for the whole year. So it shouldn't be too onerous. But yeah, if you feel that the system has been unkind to you, unfair, please do let me know. If there's
a hand up from Nassif.
Okay, Nassif, go ahead. Sorry, I can't see the hands. My computer is behaving funny today.
Hi, Prof. Good evening.
Hi.
Thanks, Dale, for the fantastic talk. Just my question is, Dale described several agents, especially for general IBS and for IBS constipation. And just wanted to know, a lot of these drugs, to be honest, I've heard for the first time tonight. Are any of those available in the state sector?
So no.
Yeah.
Carry on, Dale.
No, I was sorry to interrupt there, Prof. So unfortunately, Nassif, we are very limited in what we can actually offer patients with regards to IBS management. The only agents that we have is your, obviously, polyethylene glycol. We do have acefugla husk, and we do have 5-HT3 antagonists in the form of ondansetron and granisetron. And then obviously for pain as an adjunct, we do have your TCAs, SSRIs, and we do have a hyoscine butyl bromide. But that's kind of the limit of the bouquet that we have to assist these patients. So yeah.
So none of the secretologs that you mentioned.
None of the secretologs are available, to my knowledge, in the state sector. They are extremely expensive. Let me put it this way: dollar value for pectaclinide. You're looking at about $394 for I think it's a 2-month supply of therapy. Yeah, so it's very expensive.
Yeah, I'll agree with that. They just aren't available in the private sector. Yes, but I mean, even then, quite expensive. The rifaximin is available, but also quite expensive. So unfortunately, we don't have much to offer our patients, which is really, that's what is frustrating. I mean, when Dale said that this is debilitating for the patients, I think for us in the public sector, it's equally debilitating, because we make this diagnosis, but often we really can't help our patients. And as he said, the quality of life is good, and the health-seeking behavior and the cost to healthcare system is astronomical. And the loss, people are absenteeism and so forth. It's a real. And I know that we doctors sometimes get impatient with the patients, but this is their daily lived experience. And unfortunately, we don't have much that we can offer. All right.
Thanks, Prof. Prof, the last question that you mentioned was that, and I just think it's important to probably, for my learning, that IBS can coexist with many other organic disorders. And I'm just thinking now, the reason probably why that's important is because once you've managed that organic disorder, whether it is, whatever it is, the IBS may still persist beyond that.
Yeah.
And I think that's practically one of the challenges that we face.
Indeed. I mean, fortunately, it's not a lot of patients where there will be this overlap. But we've been caught out with patients who we thought this was IBS, and actually, because they kept coming, when we actually did more investigations, we actually found the one had IBD, and I think the other one had celiac. But fortunately, it's not a large proportion of patients. Yeah. Most of the IBS patients are otherwise healthy, no alarm features, etc., etc.
Prof,
yeah, carry on.
Sorry, Prof, to add to it, to give a number to what you've just said. So the patients with IBS in the absence of alarm features, for example, in IBD, they said that about 3.6% of patients who are labeled IBS diarrhea predominant can actually have either celiac or IBD coexisting with their IBS.
Yeah.
So it's not a tiny number, but it's the numbers are still on your side.
And also in terms of epidemiology, the IBS patients tend to be younger. And in fact, IBS with age decreases in prevalence. So, and then I think then you are moving to the realm of patients who will have organic pathology, the older patients anyway. So it's these young people that, you know, they're otherwise well, and you can safely say after doing your minimum investigations that this is IBS, you didn't really find anything else. The one other thing that I wanted to mention is that, of course, you will test for celiac serology with the IBS diarrheal types, but don't forget that 10% of patients with celiac disease present with constipation. But I mean, it wouldn't necessarily be the first test that you do in a patient with constipation. But let's say that the symptoms, you know, the patient is not getting better, etc. You may then consider doing just a tissue transcriptomiase, and then only biopsy if the serology is positive, or there's a family history or something else that makes you think that this might be a seronegative celiac. But again, that's a very small proportion of patients. It's not, you know, your general average patient. All right, I'm
Barbara
aware
has a hand up.
Oh, okay. I'm going to take one last comment, otherwise we're going to run way over. Go ahead, please.
Hi, thank you for the great presentation, Dale. Hi, Prof. I just wanted to ask, I saw that the rifaximin, you said the rifaximin was for a limited period of time. Why is that? Is it to do with the microbiome, or why wouldn't you continue the rifaximin long term?
Dale?
So they say that a two week short course, beyond the 2 week course, there's been no real added prolonged benefit. There was a concern about resistance and getting resistant species within the microbiome, but that has actually been proven. They said that the maximal benefit does not extend clinically beyond 2 weeks. There hasn't been actual further reasoning for that. It's just that, you know, beyond 2 weeks, there's no added benefit in this. They either respond fully by day 14, which is about 40% of patients who will have a response, but there's no added, you know, symptom reward for pushing longer. And it's not related to resistance or, you know, changing the microbiome to a large degree. That's just, you know, the observation that's been made.
Thank you.
Okay, thanks, Barbara.
Thanks, Barbara.
Karen, is there anyone else? No.
Looks like that's it for now.
Okie dokie. Then I got to do my speech. Okay, so thanks to you, Dale.
Thanks,
I really
Prof.
thought
Thank
it
you.
was an excellent presentation on a very big, complex topic. But as I say, I think you really summarized it very well and also made it quite practical, what a person does in the clinic. And then thanks to ECHO at the University of New Mexico and the ECHO India team for their perpetual tech behind the scenes support. The feedback form isn't available in the chat. As you know, the recordings, and I have looked, the recordings are on the Gastro Foundation website. I find them useful to go back to. I hope you do too. Thanks to the Gastro Foundation. Karen, thank you so much for what you do, again, behind the scenes, and for just helping us to organize this thing. The last presentation for the year is on the 12th of December, and the topic is constipation, fecal incontinence, and dyssynergic disorders. We've covered a bit of it as we went along, even a little bit today, but we're going to do it as a whole topic because it's a very important topic. Again, another area that is poorly managed, partly because of the poor history taking and examination, but also I think the availability of the diagnostic tools. The presenter is going to be Dr. Muchichwa. So with that, guys, thank you so much for attending. We really appreciate it. We almost there for the year, and wishing you all the best, and see you in about 2 weeks' time. Good night.